opportunity to talk with everybody tonight, and this is super informal. So we don't have any PowerPoints or anything like that. Typically, I'll just talk for a few minutes about a few things that are recent updates that are important. And then we mostly go to the questions, and we really do have 2.5 pages of questions here, but we could certainly have more. So don't be shy. Please ask questions whenever you like. And also, I'll give a shameless plug for next Thursday. We're going to do a webinar also about West Nile virus. As you're probably well aware, West Nile virus has got a good jump start on the year, unfortunately, in Colorado. And we've had quite a few cases relatively early this year. So I'm going to talk briefly about that tonight, but then we'll have a full webinar for about a half hour with Dan Pastula, one of my colleagues at University of Colorado in our department, who is a part-time epidemiologist also at the CDC. And what he studies is the epidemiology of viruses as they affect the nervous system. And so that's the little segue for what is the West Nile virus. So West Nile virus is a virus. It's primarily made up of RNA, not DNA. So it's a single-stranded RNA virus. And it's an arbovirus. It's in the family of arboviruses, which are those that are transmitted by being either bitten by a mosquito or a tick. In this case, it's a mosquito. And it's a specific family called the Culex family. And most of the infections that actually occur between birds and mosquitoes, and they can cycle back and forth between birds and mosquitoes. But then occasionally, when the mosquitoes then go off and bite other mammals, like horses and people especially, those individuals can also get affected and infected. And those are what are called dead end or incidental infections, though. That is, you cannot make enough virus inside a horse or inside a human being to then have a different mosquito come by and pick up and then transmit to somebody else. So there's no human-to-human transmission. There's no horse-to-human transmission. It's really all mosquito bites with birds circling around and then the incidental hosts. And the vast majority of people, sure, go ahead. Oh, yeah. Right. And yeah, there was no question. It was just a comment that definitely we have seen in Mesa County, where we are, have seen cases of West Nile. The first cases of West Nile in the United States were in 2003. And it blew up that year with many thousands of cases in Colorado and elsewhere. Actually, it was a year or two before that in New York, and it literally spread west every year after that. We were at the second or third wave. But there are other mosquitoes that may also be relevant, including some that have not been seen for a while. So most people, when they are infected, really have no disease. A small number of people will have sort of a viral infection, low-grade fever, headaches, achiness, perhaps a rash. And then a very small number will be having what's called neuroinvasive disease. And that means the virus is able to get into the nervous system after it's taken up into your body and replicates in other organs like your spleen and your lymph nodes. Gets into the blood, can make it to the brain or the spine. And then it can be also neurovirulent. That is, it can actually cause damage inside the nervous system. And that's a very small percentage, but that is where it can be very, very deadly. It can cause two main syndromes. The main one is any kind of encephalitis, which is an infection up in the brain proper. It can also cause a syndrome very similar to polio. And there are other viruses that can cause a syndrome very similar to polio as well, that are in different families. So polio is also an RNA virus, but it's a completely different family. But they infect what's known as the anterior horn cells in the spinal cord and can cause paralysis. It's very similar. Why do we care? Number one, anything that you have on top of your MS can make your MS worse. So if you have any infection, it's not good. But if you have an infection of your nervous system, that's particularly potentially dangerous because it can be additive or even synergistic. That is more than additive when you throw it on top of someone who has some damage to their nervous system already from MS. But also importantly, many of our patients are using medications that may alter or suppress their immune system. And Dr. Pastula published a paper in March this year looking at a number of arboviruses, including West Nile virus, and went through cases from all over the United States, and I think actually worldwide, and showed that neuroinvasion and neurovirulence were substantially higher in individuals who used specifically anti-CD20 drugs, the B-cell depleting drugs like rituximab and Ocrevus. A paper was just published last week by our colleagues at the University of Pennsylvania, and they showed that it was a substantially increased risk of having neuroinvasion and neurovirulence if you are on those medications, if you're exposed to the West Nile virus. So it's just a reminder that there are other things that are out there. They're potentially even devastating. If you have nervous system disease, the vast majority of people that die due to West Nile, and there was another case, the 11th case this year in Colorado, died yesterday. It is almost always from nervous system disease. It's not from in your lungs or some other body parts. It's neuroinvasion. So we will have a full webinar on this next week on Thursday morning at 8 o'clock. You can get to it from mscenter.org if you are interested. One very small thing. When I finished training, we had 0 drugs available to treat MS. We now have over 20. And so now we have generics. We have off-label use of, for example, rituximab, which we've been using for 15 years to treat MS. And now we have 3 other drugs in that category, Ocrevus, Kesimpta, and now Briumvi, which was approved in December, all in the same category. And we've been using biosimilars of rituximab for quite a while because they are cheaper. And so, for example, our city hospital, all of Kaiser, our VA, and many others use the biosimilar because not only is it cheaper than every other drug we use for MS, but the biosimilar is even cheaper and highly effective. Now, for the first time, there's going to be a biosimilar that just got approved, I believe, either yesterday or this morning for Tysabri. It's going to be called Tyruko or something. Yeah, Tyruko, Tyurko, I think it is what it is. And although Biogen has a number of patent objections that they have raised, and so that may cloud when it actually makes it onto the market, we'll see a biosimilar there. Biosimilars, by definition, unlike generics, generics do not have to be showing that they either lower your cholesterol or treat your blood pressure or whatever the generic is for. With a biosimilar, which is sort of a generic for a biological drug, they have to prove, in order to get approval from the FDA, they have to prove not only they are substantially equivalent chemically, not identical, but very close, but they also have to prove that they do something in human beings. So in this case, it was called the Antelope study. They compared to Tysabri versus the biosimilar, and looking at primarily MRI outcome measures, it was very similar. In fact, if anything, the biosimilar did a little bit better, but it was statistically no different. And so that will come on the market at some point. And I mentioned that just to say that A, if you're on Tysabri, your insurance company may want you to use the biosimilar because it will be cheaper. And so that's just a little bit of forewarning. And we think that's probably fine. But also it's just, there's just a maturing of our market. For many years, for the first 10 years, essentially, that we had medications, we had 3 interferon drugs, Betaseron, then Avonex, then Rebif, and we had Copaxone, and that's all I had for 10 years. Now we have over 20 drugs, and it's a completely different conversation, and the market's just matured, and we just have all sorts of different kinds of conversations compared to 25 years ago. So that's mostly a good thing. Just makes things a lot more complicated, though. In addition, my colleague, Jeff Bennett, and another colleague, Greg Owens, they have been working for many years to try to understand a very important immunological problem in MS. Many of you probably had spinal taps for diagnostic purposes, and you can see abnormal proteins, antibodies, that are in the spinal fluid that are not seen concurrently in the blood. And that suggests that they're made inside the nervous system. And we refer to those as oligoclonal bands because they are clones, Each one of the white blood cells that makes one type of antibody will only do that, will make one type of antibody. If you have 4 or more of these that are unique to the nervous system, clones, compared to what's seen in the blood at the same time, we call that positive. Now, there are other things, infections and other things that may cause so-called oligoclonal bands to be positive, but it is classic for multiple sclerosis. And so for many years, this was the major clue that MS was an autoimmune condition. But the question was, what were these antibodies directed against? Usually they're directed against a virus or a bacteria or a fungus. But in autoimmune conditions, they get misdirected, and they may, you can have an autoimmune condition that affects your kidney, your skin, your eyeballs, your kidneys. In the case of MS, it affects the nervous system, the central nervous system, the brain and the spine and the optic nerve. So trying to understand what these antibodies have been directed against for the last 80 years since they were first discovered has been a huge question, because number one, it might tell us what the target is for why does the immune system get whacked out and make these mistakes and attack you instead of what they're supposed to do, attack a virus or a bacteria or a fungus. But also would be a potential clue as to what to treat, how to treat, and also it could tell us, importantly, are these antibodies just a sideshow, like something happens in the nervous system and then these antibodies get formed? Or are these antibodies causing the disease? So in NMO, neuromyelitis optica, which is sort of a cousin of MS, the antibodies cause the disease. It used to be thought that NMO is just a variation of MS. It's clearly a separate condition. And there's other separate conditions like MOG antibody disease as well, where they have different antibodies. And those two conditions have blood tests because they have these antibodies. We've never had a blood test for MS, and we've never known what these antibodies were doing. So Dr. Bennett, who joined us in 1998, shortly after he came back from his fellowship, and is, other than myself, the oldest person in our group, who's been with the center all the way through. He and Dr. Owens, a PhD biologist, have been working for literally 28 years to try and figure out what these antibodies are doing. And the short story is this got published last week in Journal of Clinical Investigation. And they found, and so what they've been able to do, and it's sort of complex, don't worry about the details, but what you can do with spinal fluid, you can get cells out of the spinal fluid, you can separate them into a single cell, into a 96 well plate, and each one of those B cells, those B lymphocytes, can make an antibody. And what they're able to do is use very advanced molecular biology techniques to actually clone those antibodies and make synthetic antibodies from that. And then they can use those to test things in the animal model of MS or elsewhere. And so they've been working their way up piece by piece by piece for literally over 25 years. And they now have published just last week that antibodies that they have gotten out of multiple spinal fluids of actually all of our patients, because that's where all their fluid comes from, 60% of the time, the antibodies that they've been able to clone out can induce the animal model disease of MS. And when you take antibodies that are potentially made in control circumstances from people who just have other single cells that we got into a well, and you can do the exact same thing, they do nothing. So 60% sensitivity, that is picking up some antibody that's relevant, but 100% specificity, none of the controls will cause that. So number one, we've identified at least one set of antibodies that will account for up to 60% of cases of what the oligoclonal bands are. And they appear to be pathogenic, to participate in causing the disease. And that is a huge issue. And in this case, it's interesting, we knew this, that these antibodies were potentially relevant for 80 years, but it took finally, really mostly, when we started using rituximab to treat MS 15 years ago, we saw that deleting the cells that make these antibodies was highly efficacious. Subsequently, we also found that these B lymphocytes were in the lining of the brain, the meninges, leptomeninges, when people have progressive MS. So directly involved in the pathogenesis. And now this further implicates the antibodies. And why do we care? Because ultimately, when we started using rituximab, deleting these B lymphocytes, it was found to be highly efficacious. And that led to the development of Ocrevus, Kesimpta, and then also now Briumvi. And there's also a new category of medications that's under phase 2 and phase 3 studies called BTK inhibitors, Bruton's tyrosine kinase inhibitors. I won't go through all the details of it, but they also have an impact on B cells. They don't delete them. They just sort of turn down the inflammatory milieu that is in the B lymphocytes, but also, importantly, may well have an impact on a totally different set of white blood cells called microglia that live in the brain and spine. They don't circulate all over your body. They just live in your brain and spine. And why do we care? Because those are linked very closely to those B cell clusters in the meninges of the brain and lesions in the outer rim of the brain, the cortex, which are highly disabling and which are seen to be elevated in people with progressive MS. So if that is all correct, and it works in people the same way it works in the animal model of MS, then these BTK inhibitors may well play a substantial role in altering how we treat progressive MS. So that's all about the B cells, which is interesting because when I was in training, it was all about the T cells, and that's changed. You have a question? That's a good question. I'm not sure who the first author is, but the senior author is Bennett, and the other senior author is Greg Owens, O-W-E-N-S. So Jeff Bennett, usual spelling for both, 2 N's, 2 T's. And it's not in paper yet, it's only electronic. So, I mean, literally got published last week. So that's all I was going to really talk about, because I thought those were interesting sort of new things that are important. And then I really do have a bundle of questions here. So you're welcome to ask more questions, but I'm going to try and go through these all. And there's a lot of them, so if I'm sounding like I'm rushing, I might be rushing. There was a question, and just to remind what Kelsey said, this is not a consultation for your personal medical issues. This is really meant to be a discussion about larger issues for MS. And so I can't give anybody advice on how to treat this or how to treat that, because you're not my patient, and that would be inappropriate. So if I'm off-putting because of that, that's the reason why. It's really not appropriate to try and do a consult in public like that. But there were a number of questions about depression and pain and other things that are symptoms of MS, and trigeminal neuralgia, a very specific type of pain. Trigeminal neuralgia is a pretty horrible facial pain. The trigeminal nerve has 3 branches, 1, 2, and 3, from this part of the scalp forward all the way down to the jawline. And it covers sensory function over the face. And then one branch is a motor branch that helps your chewing muscles. You're all using your chewing muscles right now. That's the trigeminal nerve also. And so trigeminal neuralgia is a syndrome of pain in one of those 3 distributions, typically 1, typically either 2nd or 3rd, typically not on top, and may be caused by MS. And in a 20-year-old woman, trigeminal neuralgia is MS till proven otherwise. But in older individuals, is actually probably due to there's a very large blood vessel called the basilar artery that sits on top of the lower portion of your brainstem. And as we get older, we all get vascular disease of some level. And the blood vessel can be twisty-turny or dolichoectatic, and it can literally sit on one of the trigeminal nerve branches. In which case you actually treat that with either medicines just to treat the pain, or the father of a colleague of mine from med school, Dr. Jeanette in Pittsburgh, just died last year. He developed a way to actually go into with this incredible microvascular decompression is what it's called. You go in sort of here, you tunnel all the way down deep into the brainstem, and then you take a little piece of gel foam, stick it underneath that blood vessel, and then go back out and sew everything up. So you spend about 5 minutes actually putting the gel foam in, and spend about an hour and a half going in and an hour and a half coming out. But for people who have refractory, does not respond to medications, pain, it's like 60 or 70% effective if you have that version of trigeminal neuralgia. Doesn't work for MS though. So the typical treatments for trigeminal neuralgia are medications that we use for any other pain syndromes, and these are all borrowed from either epilepsy or from depression, other syndromes. But really, in my experience, you can also try gamma knife, which is not really a knife. It's not surgery, but it's usually sort of owned by the neurosurgeons. And it's essentially high beam radiation to the area. Essentially, the trigeminal nerve comes in around through here, and you can try and do something with the radiation. It's never been clear to me what that may treat that, at least transiently. In my experience, that does not work well. But the old-fashioned way to treat that surgically would be literally to cut the nerve. This is extremely sensitive to touch, putting anything in your mouth, on your face, air blowing on your face, extremely sensitive to sensory input, and you just cut the sensory input. It works really well, but then that part of the face is completely numb. People would trade that numbness 100% of the time for getting rid of the pain. The pain is awful. So that's an example of neuropathic pain that is treated that way. One of the questions was whether or not Botox might be able to be used for neuropathic pain, especially for trigeminal neuralgia. There are some case reports of that, and it's been used in other variations of trigeminal neuralgia and other pain syndromes. But there's never been a large, well-done controlled trial. So I would say it's certainly not the standard of care, but people will try anything for this pain if you have it. It's really incredibly difficult. Similarly, for depression, we would treat depression the same way that we would treat depression than anybody else. Depression is somewhat more common in people with MS compared to people just in the general population, but it's really popular in the general population as well. So it's a really common problem, and they're pretty much treated the same. So there's never been any like one lesion in the brain or 2 or 10 that has been the place where you get depression and MS. No one's ever been able to ferret that out. So we generally tend to treat it the same way, and we use the same medications. And we also then rely on cognitive behavioral training, talk therapy, and a variety of other things. And for both pain and for depression, there's some question as to whether or not you could use electrical stimulation. That's being studied now as well. So there are some other potential techniques that would be useful. So let's see what else we got here. Oh, related to that, there was a question about marijuana and gummies. There's no proven use of cannabis products for MS other than there's a vaporized version that's been approved in Canada and the UK. The name of which escapes me right now. But essentially, it's used primarily for spasticity, that increased tone and that tightness that many people get in their legs, especially. And for people who fail traditional therapies like baclofen, tizanidine, and other things like that, studies have shown that 40 to 50% of people will get some benefit from this vaporized version. And it's about 50-50 THC and CBD. As many of you know, cannabis products are not just one thing. There are whole families of cannabinoids, and I think there's 89 of them or something. And some are psychoactive, like THC, tetrahydrocannabinol, and some are not, like CBD, cannabidiol. And cannabidiol is used to treat seizures, really horrible refractory seizures in children called Dravet syndrome, and is approved for that purpose. There's no approved purpose for any cannabis product in the US. However, many of our patients do use cannabis products. And I would say that in my experience, the most successful use is primarily for sleep. Many of our patients have difficulties with sleep, either due to pain, having to get up at night to go to the bathroom. There's probably an increased risk of primary sleep disorders amongst people with MS as well. And so small amounts, and a lot of our patients have anxiety, which is a major contributor to bad sleep. And so small amounts of THC, like literally 2.5 milligrams, or sometimes even just CBD alone may be quite helpful for sleep, has been just my experience from talking to hundreds of patients about this. So there are some uses, and you could take it as a gummy, you could take it as a pill, you could smoke it, you could vaporize it. I would personally not suggest smoking it, because then you get whatever issues about inhaling whatever's in there into your lungs. The advantage of gummies and other ways of using it like that is that you don't do that. The disadvantage, it takes a lot longer for it to take effect. So when you use a vaporized version or a smoked version, it goes directly into your lungs, gets taken up right into the bloodstream. When you take it into your body and your stomach, then it has to go through the stomach. It goes through the liver, where it gets metabolized in part, and then it takes a much longer time to distribute. You got a question? Mm-hmm. Yeah, that's the broader use of this. So the question is, would cannabis products work for trigeminal neuralgia? Because it is a spasm also. I was using the term spasm before in a very specific term, specific way. Spasms and spasticity refers to increased muscle tone, and that's actually a different process than the pain syndrome. Different nerves, different way that they work. I'm not aware that people have used, I've never seen a study anyway, where people have used specifically cannabis products for trigeminal neuralgia. There has been studied though in neuropathic pain, and the results have been a little bit disappointing.
Dr. Corboy?
Yes.
We also had a question from the audience.
Okay, we have a question from the audience.
Can you talk about the side effects for Ampyra, what they are, and how long they might last?
Sure. Ampyra, so the question is, what is Ampyra used for, and what are the potential side effects, and what does it do? So Ampyra is, we sort of colloquially call this the walking drug for MS. It's a medication that would, in theory, help transmission along the axon cable improve. So a partially damaged nerve, which we frequently see, you'll have partial loss of its function, and this would augment the function of the electricity going down the axon cable. And this is, we've been using, and actually it's just a chemical. It's called 4-aminopyridine. The generic name for the drug is dalfampridine, and the proprietary name is Ampyra. We've been using it just as a chemical that you could get, a jug this big for $60 from a chemical company in St. Louis, Sigma. We've been using that for years, and then Accorda made a version of this that had a proprietary slow release capsule, and that was called Ampyra. Then subsequently there were generics that were made, and so there are many different products now, but they're all 4-aminopyridine. And in the studies, in the primary studies that got approval for Ampyra, about 30 to 35% of people had improved walking speed when they used this twice a day, 12 hours apart. And on the basis of that, it got approved by the FDA. Subsequently, they did other studies and showed that this was not unique to the muscles in your legs. It probably helped motor coordination in your hands. It might have also even helped some cognitive function and other things as well. But what they got approval for was walking speed. And so, as I say, maybe 35% of people get benefit from this, which means 2/3 do not, essentially. And then some people also do not tolerate it. And the tolerance issues, the biggest one we care the most about is that if you take too much of it, or if you are susceptible to seizures, you may have a seizure. And the rate of seizures is very low, but you have to have normal kidney function so that you can clear it out of your body. And you have to have never had a seizure previously. And you also, in order to get approved from most insurers, you have to walk 25 feet no faster than in 8 seconds. And in the study, 60% of people were using a walking assistance, either a cane or a walker. So they looked at very disabled patients. And so we use this quite a bit, especially for people who are on a cane or a walker. maybe even threatening to, unfortunately, go to a wheelchair. And for the people that it works, there's maybe 5%, maybe 10% of people, it's like magic. They get a significant benefit. For about a quarter, they get benefit, but not, not like that. And then the other 2/3 doesn't do much. So that's one major side effect. It's the one we care about the most. And sometimes even if someone's never had a seizure, you can have that. You would never want to double up. So sometimes people forget their medicines. They say, oh, I'll just take 2 the next time. Never do that. These should be taken no closer than 12 hours apart because you don't want a big surge of this in your bloodstream, and that's potentially a risk for a seizure. The much more common side effects are insomnia, headache, and actually, weirdly, in both phase 3 trials, increased risk of urinary tract infections. Now, it's not like everybody gets urinary tract infections. It's about 10%, and that was more than the placebo group. But it is an increased risk, and I cannot tell you why you would have an increased risk of it's not an immunosuppressive drug. This just helps electricity go down the nerve better. So I don't know why that occurs. But those are the 3 most common by far. They generally, overall, it's a pretty well tolerated medication though, and we just make sure that we don't give it to people with a history of seizures and they have to have normal kidney function. But if you stop the drug, it's a relatively short-acting drug. It's a chemical that gets cleared through your kidney. And if you go off the drug, you really shouldn't have those side effects anymore, if that's maybe what the questioner was asking. There were a couple questions about diets. It's a common question. It's a totally appropriate question because we talk all the time about what are the things that people can do other than medications. There's a lot of things people can do for their symptoms. By far the most beneficial probably is good sleep and exercise, those 2. And there's now, for example, looking at fatigue, and this was a series of questions about fatigue. There's pretty good, I'd say solid data that exercise and a variety of other techniques might be useful for helping with fatigue, much more so than the medicines we use. The medicines we use are not very good. We use amantadine, Provigil, Nuvigil, and we also use some of the stimulants like Adderall, Ritalin, and things like that. In one study recently, about 3 years ago, all 3 of the drugs, amantadine, Provigil, and Adderall, were tested against placebo in a sort of a novel crossover design where you started with one, then you went to the placebo and vice versa. And all 3 of those were found to be no better than placebo. Exercise, however, is, and there are probably 25 studies, and in a you can do what's known as a meta-analysis. We take all those studies, put them in one pile, and there's a formal way to look at them, and then say, when you take those all together, what's the answer? And with a meta-analysis, exercise is almost assuredly better than any of the drugs. So getting good sleep, if you have sleep apnea, treating it. If you have to get up to go to the bathroom 4 or 5 times at night, try and find a way to not do that. One way is to potentially use vasopressin, DDAVP. That is what that normal hormone that your pituitary makes, what that does is it just redirects, instead of sending water after you process through your kidneys, instead of sending water down into your bladder, it just sends it back to your bloodstream. So your bladder fills less. And in studies where people are getting up 5 times at night, they cut it down to 1 or 2 times at night. So better sleep and exercise are probably much more important. There are a variety of other things, mindfulness, yoga, Pilates, other things that are probably also better for fatigue than the drugs we use. So this is an area I think there's been a fair amount of research on, and I think we have to really talk about more when we have people in the office. With regard to diets, which is what got me on that to begin with, there's a lot of discussion as well as to what you can do with diet. The dietary studies are on the whole pretty terrible, not for lack of effort, but it's extremely hard to do a dietary study. When we do a study with a medication, we'll compare medication A versus placebo or medication A versus medication B, and we make an assumption that everything else is all the same between the 2 groups. The only thing that's different is the medications. And when we randomize people, flip of the coin, it usually turns out that way. That is, you can match them by age, by sex, by ethnicity, by disease duration, number of drugs they've used, any of a number of different things. But we sort of assume a lot of things. We assume that they're exercising the same. We don't ask that question. We assume they're having the same diet. We don't ask that question. So it may be that there's some other things going on that we're not asking when we're randomizing people, if those are relevant. Well, that's really a problem with food and a dietary study, because you can have everybody be exactly the same for age and sex and ethnicity and everything else. But you're going to say group A is going to have the exact same diet, every single one of them, just like as a drug study. And group B will have a different exact same diet, exactly the same, just like in a drug study. That's never going to happen. It's just not. Did everybody eat the same pizza here tonight? Nope. Not everybody even had pizza. So it's extremely hard to do it. And unfortunately, there's no winner at the end. I mean, maybe Kroger would be a winner, or maybe if it's fish oils, the fish oil people would be winners. But there's not a large drug company that's invested $200 million to do a phase 3 trial that wins at the end. So getting someone to actually do a proper study is really hard. So it's going to require public funding, and you're going to have to do a large study with over 1,000 people and follow them for 2 to 5 years. That's just, it's just never happened, and I don't see it happening anytime soon. So that's just a caveat to say that the data about dietary studies is very weak. That said, if you had to use a diet, the diets that probably have the best data to support them is probably a Mediterranean diet. And that does incorporate fish oils because it incorporates fish, but a lot of fresh vegetables. And again, the data is not the best, but that probably has the best data supporting it, not only to treat symptoms, but potentially helping with MS itself. But that is not an endorsement, and there's no, one of the questions I think was, is there like a dosage of specific fish oils? And the answer is no, that's not known. There was a question that's a very important question in a broad sense about what if you have to have an, excuse me, I got a piece of pizza caught in my throat. What if you have a major surgery? And the question was about hip surgery. Is there a risk that your MS can be problematic thereafter? Can it be exacerbated, have relapses, have worsening afterwards? And the answer is there's no data that having a surgery is bad. We do know, however, if you get general anesthesia, if you have any damage to your nervous system, in this case it's multiple sclerosis, but if you had a stroke or if you have a brain tumor or anything else, and you throw a bunch of chemicals on it called anesthesia, it might be a little bit more challenging. You don't wake up quite as crisply as a 20-year-old who doesn't have any problems with their brain. And so that we sort of warn people that say, yeah, you know, as opposed to waking up and being ready to go home after your surgery in 30 minutes, it might take you several hours. The only way that you can otherwise have a known bad outcome with surgery is if you get an infection, and then you can have a superimposed pseudo relapse. Anytime you have, say, weak left leg, you recover from your weak left leg, any kind of major stressor, and your leg gets weak again. So being overheated, overexercised, your spouse is treating you badly, you don't sleep well, you have an infection, a urinary tract infection, or a lung infection being the most common, your leg can get weak again. So that's an issue. And in addition, a second thing that can occur is that if it's a big operation and you have a lot of downtime, especially if you're relatively more disabled, you can get deconditioned very rapidly. So the question was about hip surgery and total hip replacement. Actually, people do incredibly well with. They recover, they're up on crutches walking the next day. Knee surgery, I don't know if any of you had a total knee replacement, but total knee replacements are a different kettle of fish compared to the hip. So the recovery is much longer, and people can get really deconditioned and it can take them a while to get back to where they were before. To flip that around though, if you are walking badly due to your MS, and you also need your hip replaced, when you replace your hip, you may well help out your MS, because instead of having two problems causing you to be walking, walking challenged, you have reduced that to one. And so I'm a very big fan of making sure that the orthopedists especially, and the spine surgeons, that if there's an indication neurologically for someone to get either a hip replacement, a knee replacement, or have a cervical stenosis that is released, that's pressure on here's your spine going down the spinal canal, and it gets squished with cervical stenosis in the neck. That can cause stuff that looks just like secondary progressive MS. And if you fix that, that's a big plus for somebody. So on the upside, you can really help the patient a lot, because you've eliminated, or at least helped control, a nervous system problem that is in addition to your MS. The downside is, if you get an infection or if you have a long time of recovery, you could be deconditioned. On the whole, it's a good thing generally to replace things and fix them. So there are a couple of questions about other ways to treat MS. If you really think about it, there's probably 6 things you could maybe do to try to control MS. One is to never get it. And in that regard, the first ever vaccine trial started January 6th of this year with Moderna for Epstein-Barr virus. Epstein-Barr virus, there's been accumulating data over the years, and then 2 years ago in JAMA Neurology, there was what might be 10 years from now, we'll look back and say it was a watershed paper that showed that there's a clear relationship between infection with Epstein-Barr virus and development of MS. It's not necessarily the only cause, although they claim that in the paper. It may well be necessary, if not sufficient. It may need other things on the correct genetic background and other things like that. But clearly it's relevant, and there are other pieces of information that say that too. But Epstein-Barr virus, which causes mononucleosis, causes a number of other things. It causes an unusual lymphoma in Africa called Burkitt's lymphoma. It's associated with so-called myelodysplastic syndrome in people with immunosuppression, such as stem cell therapy patients. And so this first ever viral vaccine for Epstein-Barr virus study started January 6th. And in 30 years, we might know what impact it has on MS, because obviously people develop MS long after they're infected. You get infected with Epstein-Barr virus when you're a teenager, and then you develop MS years later. So the primary outcome in this study is not, do you get MS? It's, do you get mono, and or do you just get protection against the actual infection of Epstein-Barr virus? The secondary thing that we care about is whether or not 20 or 30 years from now, if we see a drop in MS because this vaccine gets approved and many people get it, that will be interesting. So one way is if we could try to avoid it, that would be one thing to do. And second thing is what we do already, which is we deal with one aspect of the immune system, so-called adaptive immune system, and all the therapies we have, they do that. The third thing, as I mentioned before, the BTK inhibitors and microglia, that's part of the innate immune system. If effective, this will be the first drug class, the BTK inhibitors, and there's multiple drugs being studied. This will be the first class that actually affects the innate immune system. They're both important. All the relapses and stuff are all from the adaptive immune system dysfunction, and we can already treat that. I don't think we need any more drugs to do that. We need drugs that can affect the innate immune system, and that's where the money is, because that's where the progression of disability is. A fourth thing that you might want to do, am I up to 4? Yeah. A fourth thing that you might want to do, let's see, wait a minute. Yeah. Fourth thing is you might want to protect the nerves from dying. So if you have a partially damaged nerve, it can limp along. But ultimately, it will develop mutations in its power plant. The mitochondria is where you make power inside cells. And it'll eventually just fade out and die. And we think that this is a big part of what we call secondary progressive MS, this failure, essentially, of energy production that occurs because of damage previously or ongoing insults from oxidizing agents. So that's things like antioxidants might be useful, or things that can pump up energy production inside cells might be helpful. So a number of those have been tested. So far, have not worked well, but there are other studies that are ongoing. We're in discussions with a company called Clean Bioscience to, interestingly enough, look at gold nanoparticles. And they've reported and published papers showing that this enhances energy production inside cells. A fifth thing that you could do, and what the question actually was about, was maybe if there's partially damaged myelin, the wrapping around the long cable, and we know that myelin made out of protein and mostly fat will help conduct electricity better. If you have a big nerve, all the big nerves are covered in myelin. The smaller nerves, not so much. And there's partial damage to the myelin. Could you repair that better? There are a bunch of ways you could repair it, but there's inhibition of the repair mechanisms. We don't repair very well in the nervous system. No mammals do. And so can you enhance that? And the answer is maybe. A number of drugs have been looked at. None have been very effective so far or have been downright negative studies. The one that has received the most energy is clemastine, which is just an over-the-counter antihistamine. Costs you about 50 cents a day to take it. And they've been able to show that you can do two things. You can show that you can conduct electricity faster. It actually can improve in an optic neuritis model. In the old days, we would do something called evoked potentials, where you'd stick your head in a bowl. You have checkerboard squares that go back and forth like this, would stimulate the back of your eye, and then you can measure how long did it take for that to get to the back of the brain. And this is how we actually diagnosed MS before MRI scans, one of the ways. That and dropping people in hot baths. And so you can show that speed is increased when you use clemastine in someone who's had an optic neuritis. In addition, the paper was just published a couple of weeks ago. Same group also looked with advanced MRI techniques and tried to determine whether or not you could see that the nerves got bigger because of the myelin wrapping. And it appears that they do. Very small, but measurable difference. The problem with that is that when they actually looked at people's visual acuity, what could they actually see? Did they actually see better? And the answer was no. So although so it was sort of proof of principle that you could augment remyelination, but unfortunately, you could see it on a couple of tests, but it didn't do anything, for people functioning with their vision. So that at least is the proof of principle that you can do it, and people will be interested in pursuing that further. And then the last way, the sixth way, is can you grow a brain? Can you grow nervous system tissue? And when I was in training, we were told that the cells that you would need to have, these are stem cells, but they're not, they haven't gone down the lineage to become hair or a kidney or a liver. These are ones that have gone down the lineage to become nervous system cells, neural precursor cells. We were told these did not exist, and you couldn't find them in the brain or the spine at autopsy. That was completely false. They actually are there. You just had to have better techniques to find them. And one person that's been instrumental in that is a guy named Bruce Trapp, who's at the Cleveland Clinic. He was at Johns Hopkins when I was there. And Bruce has been a leader in understanding what's the cellular composition inside the MS brain. And he and others have found, even in autopsy studies of people over the age of 80, you can see these cells that are precursor cells. So, but like remyelination, they sort of get stuck. So they go down a lineage, down a lineage, down a lineage, and they sort of get stuck there, and they don't complete the differentiation, become fully functioning nervous system cells. So there's something holding it up. So trying to understand what's holding it up has been an incredible area of interest. And ultimately, it could lead to what are very, very early, like phase 1 studies, which are being done now, phase 2 studies even, where you can take these neural precursor cells, and you actually take fat cells from the belly, you treat, so this is down the fat lineage all the way over here. How the heck did they get over to the neural precursor cell side? You treat it, it goes back to become a stem cell, a fully functioning stem cell. Treat it another way, it goes down a different lineage. And so a Korean scientist won the Nobel Prize for this about 12 years ago or so. And so these are inducible pluripotent stem cells. You can induce them, and they're pluripotent. They can become anything. And so you send them down a different lineage, you grow them up, and then you shoot them in the spinal fluid. And one of two things could potentially be beneficial. One, they could simply set up shop and replace the damaged cells. That seems less likely, though, for a variety of reasons, including in animal models, where it's more likely that these neural precursor cells are emitting various growth factors and other things that will stimulate the cells that Bruce Trapp and others have found are already still sitting there. And so these are very, very early studies, but that is one way you may be able to regenerate tissue. You could also, in theory, if you could do it, you could just squirt the growth factors into the brain or the spinal fluid or the spinal cord or wherever. But in ALS, Lou Gehrig's disease, they're doing a very similar kind of thing, except they're using different stem cells. And what they're doing in that case, face down, lay a patient down, and ALS really primarily affects the spinal cord and the so-called anterior horn cells. And they unroof the back of the spine at multiple levels, and then they literally inject the stem cells, one on either side, all the way up and down the spine, in an incredible procedure. And so they are also in phase 2 studies. That is a disease that kills people in 2 years. People would be willing to try just about anything for MS, for ALS. MS, not only does it not kill people, thankfully, but we have other therapies that do work that are successful, not perfect, but certainly successful. But in addition, MS can occur all over the place. And the damage that occurs is in numerous locations, unique to every person. And so you would never be able to sort of systematically do that very easily. We've had patients ask me, at least twice in my career, people have said, I see that dot on my brain scan there. Can you just cut that out? And the answer is yes. And you don't want us to do that. That would be bad. There would be a lot of damage from that. How are we doing on time?
We are at 6:30, 30 more minutes.
Okay.
And I do have a couple of questions from the audience.
Okay, give me one.
Do you have any proposed solutions for chronic vertigo due to lesions on the cerebellum besides diazepam?
So the question is about treatment of vertigo that could be due to MS. And so the answer is that it's extremely difficult. We don't have a lot of treatments that do much of anything for cerebellar disease. The cerebellum is the back of the brain, and it's associated with a variety of different symptoms. The most prominent are ataxia, wide-based gait, as well as tremor, especially large amplitude and very slow tremor, compared to a Parkinson's tremor, which is very fine and very fast. So it's a very different kind of tremor. The medicines that we use for conditions, clinical syndromes related to cerebellar dysfunction, they just don't work very well. And most of the time it's tremor that we're talking about. And most of the time vertigo would not probably be from primarily cerebellar insult. It'd be from what's called the vestibular apparatus, which is deeper just in front of the cerebellum in the brain. But they're linked. And I think, unfortunately, the answer is no. We don't have any good treatments for that I'm aware of. And diazepam, which is Valium, probably doesn't work very well.
How is swallowing difficulty and acid reflux treated in MS? What is the feeling of heaviness in your chest if you have swallowing and acid reflux?
Yeah, if you have, so the question is about acid reflux for those who have swallowing problems. So swallowing problems are not super common with MS, but they absolutely occur. And it's just like any other motor function. It's a complicated motor function. It doesn't seem like it's very complicated, just chew and swallow, right? We all do it all the time. You learn it from day one, literally, right? When you're a baby. And so it's actually a pretty complicated thing. And if you ever watched a barium swallow test, you can see how there's this incredibly coordinated motion to propel the fluid, the bolus of food down into your esophagus and then squeezing the esophagus to get into your stomach. So the treatments with regard, and so how can swallowing problems cause you harm? One way they can cause you harm is that you swallow the wrong way. You swallow not down into your stomach and your esophagus, but you swallow into your chest. And then you can get an aspiration pneumonia, and you drag bacteria from your mouth where there's tons of bacteria, drag it right into your lungs. And that is the greatest fear with swallowing problems. So the main way that we treat swallowing problems is to essentially focus on chewing things to the greatest degree possible, cutting things to the greatest degree possible, and making sure that you essentially have the chin forward, the sniffing position, so that you can help close off your esophagus. That's the main thing to do. For people that have severe swallowing problems, people who have, diffuse muscle weakness all over their body, oftentimes use feeding tubes and avoid that altogether. So you feed through the stomach or the small bowel. So it's mainly avoidance behavior to treat that. There's no medicine or anything else that helps improve swallowing function that I'm aware of. The other part that you can have from the GI tract problem point of view is you can have acid reflux. That was the question, the second part of that question. And acid reflux can actually occur in anybody. It's maybe more common in people who are probably sitting in a wheelchair more than others. They don't have a chance to sort of clear, to get stuff down into the stomach, out of the esophagus. You can have reflux of acid from the stomach up through into the esophagus. And that's what essentially heartburn is. And that can cause a lot of pain in your chest that is often mistaken for having a heart attack. So I don't know this for a fact, but I think the number one reason why people go into the hospital thinking they're having a heart attack that is not a heart attack is actually reflux. And that is treated either with dietary issues, or there are also a bunch of things that can lower acid in your stomach as well. And then if you have severe acid reflux, you sometimes could have surgery. You can get severe scarring in the bottom of your esophagus that can really be problematic. So I think I answered that. There was a question about stem cells. Question was, how are studies coming along with treating MS without drugs? Could stem cells be used to treat it? Well, stem cells are drugs, especially the way I described before. If they're inducible pluripotent stem cells, they happen to be cells, but they're being used as a drug. But also importantly, for using bone marrow derived stem cells, which is the stem cells that are really pretty much proven to be helpful in certain individuals with MS, you actually precede the stem cells by high dose chemotherapy. So it's absolutely drugs. The drugs that we talked about a few minutes ago, the neural precursor cells, they would not require any immunosuppression at all. There would be no immunosuppression. They would just be a true cellular therapy. But maybe the broader question is, treating MS without drugs gets at all the other things we talked about before: good sleep, good exercise, eating well, reducing stress, and all those things. They all do matter. And as I mentioned, there's actually meta-analyses of a number of those approaches that are showing benefit. Related to that, there's a question about whether or not stem cells might be helpful in seniors. Depends. The stem cell studies with bone marrow derived stem cells show, and these are from small and large series, a small number of controlled trials all over the world, show that on the whole, the benefit that is achieved is the same benefit that is achieved with the presently available drugs. That is, the people who benefit the most are younger individuals with active relapsing MS. And that's because the process is that you take the stem cells out of the bone marrow, you store them, you crush the bone marrow, and then you give back the stem cells to rescue it so the person doesn't die. So it's really a stem cell rescue. The stem cells are probably some part of the treatment, but I personally think the chemotherapy is the more important. And so it's just when you do that, what you're really manipulating is the same thing that we're manipulating with the drugs that are presently available. It's just a much more sort of complete and harsher version of it. So it's not surprising that it's the same people that benefit. So for someone who's had MS for 30 or 40 years, or has primary progressive MS and they're 55 or 60, the studies have shown that unfortunately this does not work. Now we are doing a protocol with our colleagues at Colorado Blood Cancer Institute at Presbyterian St. Luke's downtown in Denver. And we're going to be using a different way of preparing not your stem cells, autologous stem cells, but allogeneic stem cells, donated stem cells, that there's at least a theoretical reason to believe might be better for progressive MS. And there's a company involved here. What they have done is they've created a system of treating the cells that greatly reduces graft versus host. And so graft versus host disease is what is a real problem when you're using somebody else's organs. So we know that all the time because, give somebody a kidney, you got to suppress their immune system, right? The graft itself, what you're sticking into the patient, can attack the host when you're using bone marrow derived stem cells. So you have to be able to deal with that. And when you can deal with that, you can use higher numbers of cells, and that may be a limitation that we presently have with allogeneic stem cells. So we'll see. We haven't given up on progressive MS in older individuals, but it's not been working so far. There are questions about brain shrinkage. We know that there are a number of things that are related to prognosis in MS. So for example, having spinal disease clinically is. Being a guy is worse than being a woman. Being African-American as opposed to Caucasian. Having progressive onset MS is worse than having relapsing onset MS. But we know there are MRI markers as well. There might be some blood markers as well, but we're not quite there yet on those. The MRI markers are not surprising. The more lesions you got and the more in your spine, the worse off things are typically. And having a lot of attacks early and then seeing that manifested in the MRI scans is bad as well. But starting about 15 years ago, when the computer techniques for measuring shrinkage of the brain became available, several things were learned. One, early brain shrinkage is common. When people have an MRI scan, maybe because they have migraine or hit their head in a car accident, and you look at it and say, whoa, that person looks like they have MS. We call that radiologic isolated syndrome. When they have a clinical event and you check, you call that clinically isolated syndrome if they don't fulfill all the diagnostic criteria of MS, which is multiple. Once they have multiple issues that occur over time, we call it multiple sclerosis. Sort of draw a line in the sand, but they're all part of the same continuum. When you take people who are young typically with radiologic isolated syndrome, never had a symptom of MS, get an MRI scan, looks like they have MS, and you look at brain volume and compare the brain volume for those individuals against age and sex matched controls who do not have that on their scan, there's already brain shrinkage before the very first symptom of MS. And it accumulates over time. And you could argue, and many people would argue, that brain volume loss, shrinkage of the brain, which everybody in this room has, well, maybe not you, you're pretty young. Okay. But begins for everybody about 30. I don't know, Kelsey, maybe not, I don't know. But everybody has brain shrinkage. It's just augmented significantly in various neurodegenerative disorders. And the fact that you can see that brain shrinkage so early is really a primary thought that MS is a primarily neurodegenerative disorder, not an inflammatory disorder, that the inflammatory stuff maybe it isn't a sideshow, but it's not the primary thing that's going on. And so measuring brain shrinkage is really important on a population level. And we use it a lot when we compare drug A to drug B. And if drug A stops brain shrinkage more than drug B does, that's a win. That's good, and that's associated because that lack of brain shrinkage is associated with a better outcome later. When you use it in an individual, it unfortunately is not, because, for example, you could get your brain volume measured at 8 o'clock in the morning, go and drink a quart of water and get retested again, it would be different. And there's also, as good as it is, it's not a perfect technique. So you have to have literally hundreds of people in these studies in this population versus 100 over here, and you're measuring 0.2 to 0.4 to maybe 0.6% of brain volume differences between them. So tiny amounts. And so you really can't do that in an individual person. So when we check the brain volumes on all our patients, and sometimes people say, my brain volume compared to age and sex matched control last year was 25th percentile, meaning that 75% of people had a larger brain volume. And I'm only 10th percentile this year. Did that mean I lost 15% of my brain last year? And the answer is no. That means there's a lot of fudge factor in the way it's measured. And that's not what we're measuring anyway, because you're really just comparing it to age and sex matched control on an individual basis each year. So it's not a total volume loss. It's just comparison to others. So brain volume does matter. We measure it a lot. And there's other MRI techniques that are perhaps going to be important in measuring progression of disability, because that's what the brain volume is really important at sort of predicting. And there's things called phase rim lesions, or pearls. And they're lesions, and you can see in the rim when you use certain techniques, you can see active, those microglia and macrophages I mentioned before, you can see those active. And that suggests even in progressive MS patients that there's ongoing inflammatory disease activity, except it's different from what you see in someone who's newly diagnosed with relapsing MS. And then also slowly expanding lesions. We know that one of the things you can see with MS is you might have 2 lesions, and then they sort of grow together because they slowly expand and run into each other. And that is also associated with progression of disability. So coming up with better techniques like that, and/or to come up with techniques that can actually look at integrity of the cables, the axons, and the myelin covering them with a variety of other techniques will be very important as we go forward, trying to show nerve regeneration, for example, or remyelination. So these advanced MRI techniques, which are not commercially available yet, have the possibility of really expanding how we think about MS and measuring potential benefits. Yep. Yeah. And what's the question? So the question is about spasticity, and sometimes the medicines that we use do not work very well and/or are not tolerated. And so in that context, you can do some other things. You can use Botox, depending upon how much muscle tissue you're talking about, and Botox is effective. You can also use baclofen pump. Baclofen pump is implanted under the skin. It's about the size of a hockey puck. Literally, it looks like a hockey puck, except it's titanium. And it's got a catheter that comes out the side. You snake it around, and it drips tiny, tiny amounts onto the spinal cord, and like 1/1000th of the dose. So for people that don't tolerate baclofen because it makes them very sedated and sleepy, you can do that directly, and you have none of those central nervous system side effects. So there are other ways to treat spasticity that don't involve just the oral drugs. Did want to talk, there are several questions about disco MS. I've somehow created the monster that people think that I take everybody off their drugs because I'm the one who wrote the grant, we did the study. The fact is we don't take everybody off their drugs, and we treat people very aggressively, especially when they're younger, when the meds work the best. But it's a real question as to how long you need to use those medications. the MS changes as people age with less new relapses, less new scan changes. Some people just sort of flatten out and nothing is changing. Some people go into progressive phase of MS where the medicines actually just don't work very well. They may work somewhat, but not that well. And so these drugs are expensive. They have potential risks associated with them, especially with more highly effective drugs where infection is a substantial risk. And people don't like taking drugs if they're not doing anything for them. And so there's always an assessment as to whether or not the potential risks of the medication, the cost of the medication, the hassle factor with the medication outweighs the potential benefits, because the benefits are going down with age with the presently available drugs, and the risks are going up. And unfortunately, the costs are going up because every year the costs go up. So we did the Disco MS study, and we looked at people 55 and older, in part choosing 55 and older because the natural history shows that by age 55, most people are not having very many relapses. And in addition, there's virtually no data that these drugs work above the age of 55 because people haven't been studied above the age of 55. That is, the cutoff has been 55 in almost all the studies. There's a few that go up to 65, and most of those studies are negative. So there's really very little evidence that these drugs do anything over the age of 55. When you do sub-analysis of different age groups with these drugs in these subgroup analyses and all these studies, the vast majority of studies, and they usually say above and below the age of 38, above and below the age of 40, and the maximum age being 55 when people start the study, they show that there's almost no benefit in people over the age of 40. I mean, there's some, but it's dramatically driven by the younger patients in terms of who's benefiting. So we chose 55 or older, stable on the same drug for the last 5 years with no relapse, stable by MRI with no MRI scan change for 3 years. And then ask the question, if you randomize half the people stay on drug, half people go off drug, what is the likelihood that they're going to have the proportion of people that have either a new relapse or any new scan change on their MRI of the brain over a 2-year period of time? And then we asked secondary questions. Was there a greater progression of disability in people who went off drug? And also, what about symptoms? Did their symptom scores change in a bad way? Did their cognitive function on something called a SDMT worsen more? And what was the patient's satisfaction with their treatment choice, or not treatment assignment, either on drug or off drug? And the primary outcome measure, though, the one that was the one we predefined, was whether or not I had a relapse and or any new scan change. And we picked a single new lesion. In retrospect, had we known what we know now, which is not available when we planned the study, we probably would have chosen 3 or more lesions, because studies show that 1 or 2 new lesions on a brain scan is not really associated with an increased risk of disability 5 to 10 years later. 3 or more lesions is, an active lesion is, a relapse is, but 1 or 2 new lesions is not. But that was the way we did it. We did a non-inferiority test. We didn't try and prove that one, on drug or off drug was superior. We tried to show that the new treatment, going off drug, was not inferior to the old treatment, staying on drug. And there were 3 possible outcomes. 1, you could show it was clearly inferior. 2, you could show that it was not inferior, or something in between. That is, you couldn't prove that it was non-inferior, but it wasn't obviously inferior. And I know that's a lot of double negatives, so just take my word for it. And so we in fact could not show it was non-inferior, but also did not show it was inferior, because there was a slight increased risk of having 1 or 2 new dots on your brain scan. But really, clinically, there was almost no difference between the groups. There were almost no relapses. There were only totally 4 relapses among 259 people over 2 years. So very few relapses at all. 1 in the continue group, 3 in the discontinue group, 1 of which was actually not a relapse because it was my patient. And the patient actually had a herniated disc in their neck that caused their arm numbness. So it was misclassified, but the blinded observer called it a relapse, so we called it a relapse. But there were more events that were 1 or 2 new lesions on the brain scan. And of the 22 events total, so less than, it's right around 8% total, 22 events in the 2 groups together over 2 years, or about 4% a year. So very, very few. And we actually predicted 2%, so we're actually pretty close. 68% of all the new activity that was seen was just 1 or 2 new dots on the brain scan. So it was heavily driven by the MRI outcome measure. And that was not statistically different, but it was numerically greater. But there was no difference in progression of disability, people on or off drug. There was no increased risk of MS symptoms. There was no increased risk of cognitive impairment with the SDMT. And patient satisfaction was identical when people started, because they were both on drug at the time. 78% of people were happy with their therapy. And over the 2 years of the study, the people stayed on drug. It was almost identical at 78% at the end of 2 years. And it was 91% of the people went off drug. So they were actually happier going off drug than staying on. So the primary outcome measure, it was a failure. That is, we could not show non-inferiority. And it might be inferior to go off. But again, most of that was due to 1 or 2 new dots in the brain scan. So we couldn't show non-inferiority. But when you take the summation of all the clinical activity, all the MS symptoms, the cognitive testing, the satisfaction with treatment, clinically, there was not much to say that there were differences between the groups. And so in that context, are people willing to take a risk that they would have more, 1 or 2 new dots on their brain scans at a slightly higher rate than if they stayed on their medication? And that's the question. And everyone will answer that differently. We certainly didn't say, well, that means everybody should go off their medication. That's not at all what you conclude. You could conclude from that. You can conclude that, life is messy and it doesn't give you a perfect answer. And we need more longer studies. So we did a longer study. So we took a subset of the people from the original study. And this isn't published yet and it hasn't been really reported yet, so I'm not going to tell you all the details. But essentially, in this subset, and it's people who finished the original study, remained on the same assignment, either on or off drug, that is, they didn't switch back and forth. They didn't already reach the primary outcome measure. And they had to be at one of the 10 largest centers, that is, the people who recruited the most, because we didn't have money to have all 20 centers participate. We only had enough for 10. And so we only got 74 people out of the original 259. But now we're followed out to 40 months on average. So a substantially longer period of time. And when we did that, we saw no new relapses and minimal new disease activity on the scans, and no difference in all the other stuff, just like we did at the beginning in the primary study. So that's a little bit more data. It's not perfect, but I think the way to think about it is what we did not see. We did not see an explosion of new activity. But what are some of the limitations with the study? This is a really, narrow subset of people. The average time from last relapse in our original trial was 14 years since the last relapse. 75% of the people were on old injectable drugs like Copaxone and interferons. So these are people who had been stable for a long time. We had 2 people on Ocrevus. I think 13 on Tysabri. So we could not tell you anything about the newer drugs and what happens when you go off those, for example. So there are a number of limitations, but the data is what the data is, and then people will make of it what they make of it. And but the goal from the beginning of the study was not to say, geez, we want to get everybody off drug. Our goal was to figure out what the heck happens when you do, because there's just no data. So now we got data. So we'll see how people use that and what happens with that. Let's see. That actually answers that whole page is about disco. Yeah, that covers it. So we have about 1 minute left, or no?
We have a couple minutes.
Couple minutes. Who's got a question? Go ahead. Or you have one there too?
I was going to do just a quick one.
Okay.
If I have secondary progressive MS, can I safely donate blood?
Thank you very much. Can you donate blood if you have any kind of MS? The answer is yes. This has gone back and forth with the blood donation systems around the country over time. And at present, the answer is yes. There's a little bit of a question. If you're taking a medication that would potentially suppress somebody's immune system, and you give blood, what happens to that drug? Does it go into the other person that receives the blood? Probably not much, because you're really giving cellular products. So that's never been an issue. I mean, and they screen your blood for HIV and hepatitis B and hepatitis C and all those, and those are much more of a risk. So the answer is yes, you can donate blood. You had a question, no? Mm-hmm. Uh-huh. You know, so the question is about Mitt Romney's wife, who does have MS. And she has given a lot of money primarily to the groups in Boston to look at MS and perhaps other autoimmune conditions. I'm not sure the full scale. I'm sure there have been things published from it, but nothing dramatic. But thank you for the segue. It's incredibly important that people donate to the Rocky Mountain MS Center, Mitt Romney and his wife donating to the centers in Boston, to the National MS Society, all of them who are, looking at research to get at the underlying cause of treatments of this condition. So for those of you who have donated, thank you very much. We really much appreciate it. You can come to the gala on September 16th if you really want to show your happiness. And there's just no substitute for it. I mean, literally, when I got out of training, 0 medications, and now we have 20. And that's just in my puny little career. And so the reality is that there have been dramatic leaps and bounds. And to even be talking about like gold nanocrystals producing energy inside cells is kind of crazy. I mean, no one would have anticipated anything like that. And when I was in training, a lot of people wouldn't go into neurology because there was a lot of diagnose and adios. There were a lot of conditions we could diagnose and we couldn't do anything about them. And so we had Alzheimer's, we had ALS, and we had MS and other neurodegenerative conditions. No one would have predicted what happened with MS. Everybody would have predicted what happened with Alzheimer's or ALS and whatever, that they're going to be really hard to treat. We have done leapfrogging over them in comparison. And it's because the combination of NIH, pharmaceutical companies, private philanthropy, and many others who have spent a huge amount of effort and time and money to work on these problems. And there's just no substitute for trying to get to the bottom of it all. So thank you very much. And so thank you for coming tonight. We know you have many things you can do on a beautiful night in Grand Junction. And you still could, because it's light out for about another hour and a half, 2 hours. And so thanks for coming, and we look forward to seeing you soon.
Thank you. And I just want to say thank you as well to everyone. Just a reminder to please make sure that you are on our email list or our Facebook. That is how you hear about all of the great programs that we're doing. We have our Ed Summit coming up on November 4th. We just published the agenda for that. We'll be discussing research updates, Ampyra, which is progression independent of relapse activity, the differences and similarities between NMO and MS, a case study on cognition, and addressing mobility concerns in MS. So it's a really great agenda. That is November 4th. You can attend in person in Aurora or online. And then if you would like more information on the DISCO study, we have both a really great article and a really in-depth webinar. Both of those are on our website, mscenter.org. Just search for DISCO. Or if you're filling out an evaluation, put it in the comments and I'll email it directly to you. So thank you, everyone.
And West Nile Thursday.
Yes.